I invite Dr. Purnachandra Tejaswi on stage.
Good evening. Thank you, Dr. Ayyappan and team, for the wonderful opportunity. It has been a wonderful meeting so far. I'll be presenting on the video technique for HAGL lesion repair. So I'm from Hyderabad. So this is a 29-year-old male police officer. He's a kabaddi player. He fell onto his left shoulder. When he fell, he was in hyper-abducted position, and he had a dislocation which was reduced. This was his third dislocation. 6 weeks later, when he started his movement, he continues to have pain. An MRI was done, which showed a HAGL lesion in all the sections. So these are the MRI sections. So now we decided to go in. Patient is in lateral decubitus, scope in the posterior, 30-degree scope. This is diagnostic round, shows a small Hill-Sachs defect, but nothing big. And regular antero-inferior and antero-superior portals are created. The antero-superior portal becomes the further viewing portal for the entirety of the case. This is usual till now. And once this is done, scope is shifted from the posterior to the antero-superior portal. So, and this is the bird's eye view of the glenoid. You can see that antero-inferior part of the glenoid is bare, suggestive of a chronic dislocation, not much bone loss. As you can see, some bone present anterior to the bare area. When I see my scope up, that is the HAGL lesion that I see just capsular rent just next to in the humeral neck, just next to the IGHL. Once this is done, the next step is to create a posterior-inferior portal, which is quite lower than the usual posterior portal, and a 8 mm cannula is inserted. When I do this, I avoid putting cannulas in the actual posterior portal so that there is overcrowding of portals. So this is how it will look. I'm looking from antero-superior, one cannula anteriorly and one cannula in the accessory posterior portal. Then for the anchor insertion, I use a percutaneous portal, which this portal is quite inferior to the antero-inferior portal. And then in this case, I'm using a 1.3 knotless all-suture anchor. This is the first anchor you can see on the right side. This is how the portal is there, quite inferior, just above the axilla. However, this portal is quite safe as we are doing under direct vision. Once that is done, remember this is a left shoulder. I'm coming from posterior. This is a right curved, right angle, 90-degree lasso. Take bite into the IGHL, make sure that we take a robust bite. Once that is done, the usual technique that we do for the labral repair, suture the lasso onto the anterior portal. So this is an opposite curve lasso for the left shoulder, that is 90-degree right-sided curve. Once this is done, this anchor has 3 sutures. One is called the repair stitch that is shuttled into the lasso and posteriorly, and all the sutures now are taken into the anterior portal, both the repair stitch and the shuttle stitches. And the repair stitch is shuttled so that the repair stitch engages the tissue into the anchor and locks it. So that is how it is done. The repair stitch is shuttled into the lasso loop in the shuttle stitch, and when it is pulled, you can see that the entire capsule along with the IGHL is getting pulled onto the glenoid neck very nicely. You can say the advantage of this anchor is it can be tightened and slowly tensioned. Once this is done, the suture is cut, but once this anchor is applied, we can see that there is still a little bit of capsular rent and a little bit of AIGHL that is falling down. So it is imperative to repeat the same thing using the second anchor. The same 1.3 knotless all suture anchor is used. In the second case, in the second anchor, I use a slightly different technique. We take a normal 30-degree lasso of the same side and come from anteriorly instead of posteriorly because the angle seems appropriate. Actually, you can see here that because already there is tension in the AIGHL, it tends to skid off. This shows that the repair is already robust. You need to just push it down and get a good bite, second bite, and the same thing is repeated here. So that's the second suture going in. Make sure that there are no knots or entangle in the suture here. So that there are a couple of entangled knots which are dealt with because this will prevent a tightening of the tissue against the humeral neck. Once this is done, the same steps are repeated. Same steps are repeated, and to finish, this is the end of HAGL repair. In this case, because we all know that in 15% of cases or 20% of HAGL lesions, there are associated lesions. In this case, there was an associated anterior-inferior labral repair, which was repaired in the general usual fashion that we always do. So this is the end of the repair. So in conclusion, patient in lateral decubitus, diagnostic round, create your anterior-inferior and anterior-superior portal, then shift your portal to anterior-superior, which is the viewing portal, then create your accessory posterior-inferior portal under direct vision and secure a cannula, avoid two cannulas posteriorly to avoid overcrowding, then a percutaneous inferior portal, which is further down to the anterior-inferior portal, is created for direct anchor insertion. Then sequential repair of HAGL lesion to recreate the hammock is the goal. Finish with anterolabral repair if required, or any other concomitant lesions, and do the shift. Rehab, the patient is in a sling for 3 to 6 weeks, followed with only pendulums allowed. Active assisted is started from 3 weeks, and active movements are started from 6 weeks. Thank you.
Excellent presentation. One question, was the MRI plain or arthrogram?
This was a plain one. This was a 3 Tesla plain one.
Okay, so you already could see the HAGL lesion in that?
Yeah, in this case, we could see, yes.
All right.
Very nice video and nice technique. Excellent.
Thank you.
Purnachandra,
Yeah.
here.
Yes, sir.
When you put the anchor into the humerus, is the axillary nerve anywhere nearby?
No, sir. In this case, the axillary nerve is not nearby because it is one thing is it is a very small incision. Of course, there is a risk of damage, but the axillary nerve is further medial and more inferior. This is just around 2 centimeters inferior, and the axillary nerve is away from this. Why I'm telling this is because I work with Ivan, and this is where he does the Halifax portal, quite inferior, and that area he has shown that anatomically it is quite safe.
Okay.
So it was my question. So if you can tell us exactly where is it a 5 o'clock portal, or is it different?
It's more or less the 5 o'clock portal.
Yeah.
It's more or less, yeah.
Thank you, Purnachandra sir.